Picture this. A sudden, sort of silent storm brewing inside your abdomen. A real medical whodunit, where the main supply line to your intestines gets cut off.
That's acute mesenteric ischemia, or AMI. It's a really critical situation.
Yeah, where blood flow to the intestines just suddenly stops or gets severely reduced.
What makes it so dangerous is that it's notoriously tricky to diagnose. It mimics a lot of other things.
It really does. And looking back, I mean, the history is pretty sobering. Mid-20th century, even with surgery, the mortality was, what, 70 to 90%?
Staggering numbers, yeah. It really highlights the progress, but
Yeah.
also, the challenges that still remain.
Right. Then the 70s brought angiography, actually seeing the blood vessels in real time.
Exactly. That, combined with more aggressive surgery, really changed the game. Mortality dropped to around 50%. A huge leap.
Still 50% though, and even now, today, for patients who need revascularization, getting that blood flow back, the in-hospital mortality is still hovering around 17 to 21%.
Which tells us, yeah, we've come a long way. But AMI is still a really formidable opponent in medicine.
So for this deep dive, we're digging into a key source, a chapter on acute mesenteric ischemia from Rutherford's vascular surgery and endovascular therapy. Basically, the expert consensus.
That's the plan.
Our mission today,
Yeah.
unpack this. What causes AMI? How do doctors figure it out? What treatments are there? We want the crucial stuff without getting totally bogged down in the details. Ready to jump in?
Let's do it. So first off, how common is this? Turns out, AMI is pretty rare, less than 1 in 1,000 hospital admissions.
Wow, that is rare. But here's something that jumped out at me. It hits women 3 times more often than men.
Yeah, that's a significant finding. And it's typically seen in older patients, often folks who have, multiple other health problems going on.
Does the chapter explain that gender difference? Why women?
It doesn't really speculate on the why for the gender gap, but it does strongly link AMI to older age and those pre-existing conditions. And those conditions often tie directly into the different ways AMI can actually happen, like arterial embolism.
Right, where a clot travels from somewhere else.
Exactly, and lodges in a mesenteric artery, blocking the flow.
And the textbook points to the usual suspects for those clots. Heart issues like AFib or flutter, maybe recent heart attack, heart failure.
Or even previous clots in, say, your arms or legs. Those can break loose too.
Yeah, the chapter says about 1/3 of patients with a mesenteric embolus have had a clot event before. And get this, up to 68% might have other clots lurking elsewhere at the same time.
It's like a systemic issue for some people. And rarer causes are mentioned too, like valve problems, endocarditis, aortic aneurysms, or even recent catheter procedures.
And there's an anatomical reason it often hits the superior mesenteric artery, the SMA.
Yeah, the angle it comes off the aorta makes it kind of a prime target. The emboli often gets stuck right near the top, just past the first few branches supplying the jejunum, part of the small intestine.
Which, interestingly, often spares the very first bit of the small intestine and the ascending colon, like a predictable pattern.
Yeah, it often is.
Okay.
But then you have smaller clots, these atherobuli, like tiny bits of cholesterol plaque breaking off.
Ah, and they travel further down.
Right, lodging in smaller vessels,
Yeah.
causing more localized damage. So it's not always one big blockage.
Okay, so that's embolism. What about the next type, arterial thrombosis?
This is different. Here, the clot forms right there in a mesenteric artery that's already narrowed by atherosclerosis, that plaque buildup.
And the chapter suggests this might actually be more common than embolism now, over half the cases.
That's what recent studies indicate, yeah. And autopsy findings back this up. Significant narrowing in mesenteric arteries is surprisingly common, especially as people get older, up to 60% of folks over 80.
Wow, and higher rates if you already have peripheral vascular disease, right? Like clogged pipes elsewhere.
Exactly. The interesting thing with thrombosis, though, is the onset can be slower, more gradual than with an embolism.
Why is that?
Because the body might have had time to develop collateral circulation, little detour vessels, basically.
Like back roads for the blood flow?
Kind of, yeah. So the main artery narrows slowly, and these collaterals compensate, sometimes for a long time until maybe a smaller event or low blood pressure finally tips the balance.
Makes sense. And people who've had previous stents or bypasses in those arteries are also at higher risk for this thrombotic type.
Yes, things like in-stent restenosis or bypass graft problems definitely increase the risk.
Okay, embolism, thrombosis. Then there's NOMI, not occlusive mesenteric ischemia. This one sounds really different. No actual blockage.
That's right. No physical clot or plaque obstruction in the main arteries. Instead, it's caused by severe blood vessel spasm, vasospasm, usually in the SMA.
But it accounts for like 20% of cases and has the highest mortality. That Seems counterintuitive if there's no blockage.
It does, but it's often because no MI happens in patients who are already incredibly sick from something else.
So it's complication.
Often, yeah. Linked to critical illness, shock states like severe low blood pressure, dehydration,
Yeah.
post-cardiac surgery patients, folks on dialysis, they're at higher risk. Less commonly, things like aortic dissection can trigger it too.
So what's the theory? Why does the body spasm like that?
The leading theory is it's a protective mechanism gone wrong. During severe stress, the body tries to shunt blood to the absolute essentials, heart and brain, and it does that by clamping down on vessels elsewhere, including the gut. It's like internal triage.
Protecting the core, but starving the periphery, in a way.
Exactly. And certain hormones, like vasopressin and angiotensin, are involved. Even some medications used to raise blood pressure in the ICU, like epinephrine or vasopressin itself, can unfortunately contribute.
Oh, wow. So the treatment could potentially worsen the problem?
It's a risk, yeah. And the chapter points out this spasm can stick around even after the original problem, the shock or whatever, starts to get better. The gut's own blood flow regulation just gets overwhelmed.
So, regardless of the cause, traveling clot, local clot, or this intense spasm, the end result is the same. Bowel ischemia. Not enough blood to the intestines.
That's the common pathway, yes.
Yeah.
But the gut does have some resilience built in.
Really? How so?
Well, only a fraction of its capillaries are open at any one time, and it can actually manage normal oxygen consumption with only about 20% of its maximum blood flow. It has reserve capacity.
Okay, so it can handle some reduction. Does it actively try to compensate?
It does. The smooth muscle and the small arteries can relax directly, and there are metabolic responses to low oxygen byproducts like adenosine. The lining, the mucosa, can also get more efficient at pulling oxygen out of the blood when flow is low.
But that can only go so far, right?
Exactly. If the lack of blood flow goes on too long, damage starts. And the mucosa, the inner lining, gets hit first because it's got really high energy needs.
And what happens then?
That leads to problems absorbing nutrients, and you might start seeing blood in the stool. That's often the first sign that the barrier is breaking down.
Okay, so given all this, how do doctors even start to suspect AMI? You said it's tricky.
Super tricky. The initial symptoms are often really vague, just general belly pain, maybe nausea, vomiting, feeling generally unwell, malaise.
Not much to go on.
Not at all. And the kicker is, often there's no significant tenderness when the doctor examines the abdomen early on, even though serious damage might be starting inside. Pain out of proportion to the physical findings, we sometimes call it.
That sounds incredibly difficult. Does the way it starts give any clues, like embolism versus thrombosis?
Sometimes. Embolism is often more sudden, traumatic, really severe pain, rapid decline because the blockage is abrupt.
Okay.
Thrombosis, because of those potential collateral vessels we talked about, can be more gradual. Patients might have had pain, bloating, maybe diarrhea for days or even weeks before things get critical.
And no.
That's the most unpredictable. It often happens in patients who are already critically ill in the ICU, so getting a clear symptom history is tough. The AMI symptoms get masked by everything else going on.
So these symptoms could easily be mistaken for, well, lots of common things. Gallstones, pancreatitis, appendicitis.
Exactly. Pancreatitis, cholecystitis, diverticulitis, even a simple bowel obstruction. The overlap is huge, which is why, the chapter notes, diagnosis gets delayed in up to 60% of cases.
60%? That's huge. And delay is critical, right?
Absolutely critical. Survival rates drop significantly if diagnosis is delayed. For SMA embolism, for instance, survival goes from maybe 50% down to 30% if you wait more than 24 hours after symptoms start.
Wow. So time is truly of the essence. High index of suspicion needed, especially with risk factors.
Definitely. If someone has risk factors and sudden severe abdominal pain, you have to think about AMI and move quickly to imaging. It could be life-saving.
What about lab tests? Do they help pinpoint AMI?
They can tell you how sick the patient is, sure. Things like a high white blood cell count, acidosis, high lactate levels, those can indicate tissue damage is happening.
But they don't definitively say, yes, it's AMI.
No, not definitively.
Yeah.
And crucially, normal labs don't rule it out either. They're more indicators of severity if ischemia is present.
Got it. So useful for assessing the overall picture, but not diagnostic on their own.
Pretty much. You might see signs of dehydration, like hemoconcentration, maybe an elevated white count, an anion gap. Other markers like amylase or liver enzymes aren't very reliable for AMI.
Are there any newer lab tests being looked at?
The chapter mentions a couple like D-dimer, which might help differentiate from bowel obstruction sometimes, and IFABP, intestinal fatty acid binding protein, as a potential early marker of gut injury. But neither is really standard practice yet.
So labs are helpful but limited. It really sounds like imaging is where the diagnosis happens. You mentioned a shift towards CT angiography.
Yes, CTA has really become the cornerstone. Traditional catheter angiography used to be the gold standard, threading a catheter up and injecting dye.
Right.
But CTA, basically, a specialized CT scan with contrast dye, is available 24/7 in most places. It's fast, and it's highly accurate for detecting mesenteric ischemia. Sensitivity and specificity are up in the mid-90% range.
And it shows more than just the main arteries.
That's the huge advantage. You see the arteries, the veins, the bowel wall itself, the surrounding tissues. You could look for the clot or narrowing and see signs of bowel damage and rule out other causes of pain. It's a much fuller picture.
The chapter mentioned biphasic CTA too. What's that?
So standard CTA catches the arterial phase when dye lights up the arteries. Biphasic adds a later venous phase scan.
To see the veins draining the bowel.
Exactly, and also how well the bowel wall itself is being perfused over time. It can pick up more subtle problems, increasing the sensitivity. It's like checking if the delivery trucks and the packages are getting through.
And what are those red flags on the CT that scream bowel damage?
Key things are changes in bowel wall thickness, thick or thin, gas in the bowel wall, which is called pneumatocyst, or gas in the portal vein. Also, clots in the mesenteric veins or abnormal contrast enhancement patterns in the bowel wall. Those are all bad signs.
What about MRI? MRA, magnetic resonance, angiography.
MRA is another option.
Sure.
It's great for looking at blood flow and vessel narrowing without radiation, or the iodine contrast used in CT, which is good for people with kidney issues.
But downsides in an emergency.
Yeah, it takes longer. The patient has to lie very still. It might not be available 24/7. And some of the subtle signs of bowel ischemia visible on CT can be harder to spot on MRA. So CTA is generally the go-to for acute situations.
Okay. So CTA is king for diagnosis, but traditional angiography isn't totally gone.
Not at all. Less for initial diagnosis now, but its role in treatment has actually grown significantly.
Yeah.
For performing endovascular procedures, fixing things from inside the vessel, and for hybrid approaches combining open and endo techniques. And sometimes, if the CTA is unclear, angiography can still help diagnose NOMI. It shows specific patterns of spasm that string of sausages look, narrowed branch origins, spasm in smaller arteries, poor filling of the tiny vessels, things that point to spasm, not a blockage.
And just to be clear, plain x-rays or ultrasound not very useful for acute mesenteric ischemia.
Generally not for the acute diagnosis, no. Plain x-rays are often normal or show nonspecific signs. Ultrasound is great for chronic mesenteric ischemia, looking for narrowed arteries over time, or for finding other things like gallstones. But in an acute setting, getting good views of the mesenteric vessels with ultrasound is often difficult, especially in sick patients with distended abdomens. It's also hard to see emboling well or assess bowel perfusion directly, so limited role acutely.
Okay, diagnosis made hopefully quickly via CTA. What's the treatment plan?
It depends on the cause. For embolism and thrombosis, the main goals are rapid revascularization, getting blood flow back, and removing any dead bowel.
And for NOMI?
For NOMI, the primary focus is fixing the underlying critical illness that's causing the spasm. Different strategy.
Let's talk about the immediate steps first. For anyone suspected of AMI, what needs to happen right away?
These patients are often incredibly sick, maybe septic, organs starting to fail. But the chapter stresses you don't wait to fix everything before trying to restore blood flow.
So resuscitation and revascularization happen kind of in parallel.
Exactly. Start 4V fluids immediately, correct electrolytes, give broad-spectrum antibiotics early because bacteria can leak from the damaged gut, and start intravenous heparin, a blood thinner, to stop more clots forming. It's all hands on deck.
What about low blood pressure? That seems tricky if you need blood flow to the gut.
Very tricky balance. You have to be careful with vasopressors, drugs that raise blood pressure by constricting vessels. Some types can actually worsen gut ischemia or make NOMI spasm worse.
So which ones are preferred if needed?
The recommendation is to use agents with less gut vasoconstriction, like maybe low-dose dopamine, dobutamine, or milrinone, if you absolutely need pressure support. Avoid pure alpha-adrenergic agents if possible, even after blood flow is restored.
And for NOMI specifically, since there's no initial blockage to fix?
Right, you focus on the underlying cause, optimize their heart function, try to wean off those potentially problematic vasopressors, stop any drugs like digoxin that might worsen spasm.
What about drugs to directly relax the spasm? Vasodilators.
Some studies looked at infusing vasodilators directly into the mesenteric arteries via catheter. The evidence is a bit mixed, though, and there's a risk of dropping blood pressure further in unstable patients, so it's not routine everywhere. Surgery for NOMI is usually just to remove dead bowel if it comes to that.
Okay, shifting to physically restoring blood flow for embolism or thrombosis, what are the open surgical options?
Well, overall surgical treatment for AMI has actually gone up since 2000,
Really? Why?
mostly driven by a big increase in endovascular procedures. Open surgery rates stayed about the same. But the key thing is, this increased use of revascularization overall is linked to lower mortality. So actively fixing the flow helps.
Makes sense. So what are the main open surgeries?
Two main ones, embolectomy and bypass. Embolectomy is literally removing the embolus, the clot.
How do they do that?
Surgeon makes an incision, exposes the SMA, makes a small cut in the artery. Sometimes the clot pops out. Often they use a special balloon catheter, pass it past the clot, inflate it, and gently pull the clot out.
Okay.
You want to see good, strong, pulsatile blood flow coming back. If little bits are stuck further down, they might gently milk the vessels or infuse a little clot buster like TPA right there. Then they carefully stitch the artery closed, maybe with a patch if needed.
And bypass surgery, when is that used acutely?
It's more common for chronic disease, but important acutely for thrombosis cases where the blockages are long or severe, where just removing a clot or stenting won't cut it. You reroute the blood flow around the blockage using a graft.
Like a detour. Where does the detour start and end?
The inflow where the new blood comes from, and outflow where it reconnects past the blockage, usually the SMA. Inflow could be the iliac artery in the pelvis, especially if the patient is unstable, as clamping the aorta higher up is riskier. That's a retrograde bypass, running upwards.
Retrograde, okay.
Or if the iliacs are bad, maybe the aorta below the kidneys. If those aren't options, you can do an antegrade bypass from the aorta above the gut arteries, running downwards. That part of the aorta is often healthier, but it's more complex exposure. Surgeons pick the best route based on the patient's anatomy and condition.
And the graft itself, what's it made of?
If there's no dead bowel or contamination, often a synthetic tube, Dacron or PTFE, they're readily available, work well. But if there is contamination, like from bowel removal, you really prefer using the patient's own vein, usually from the leg, because synthetics get infected easily.
Right, infection risk is a big concern.
Huge. And they always try to cover the graft with protective tissue, like the omentum, to shield it.
Okay, that's open surgery. Now, the endovascular options, the less invasive ones, these sound like they've really taken off.
They really have. Much more common since 2000, now the most frequent way to revascularize for AMI, and also linked to better survival.
What techniques does that include?
Things like thrombolysis, clot-busting drugs through a catheter, mechanical thrombectomy, physically removing the clot, angioplasty, ballooning the vessel open, and stenting, placing a mesh tube to keep it open, all done through small punctures, usually in the groin.
The chapter seemed a bit cautious about using just clot-busting drugs acutely.
Yeah, because chemical thrombolysis alone can take time, and while you're waiting, the bowel might be dying. Plus, the drugs increase bleeding risk, which is bad if the patient needs surgery anyway or has fragile bowel. It's more often used with mechanical methods now to clean up residual clot.
What about stenting? Seems like a quick fix for a blockage.
Stenting can be very effective for rapidly restoring flow, especially if there's an underlying narrowing causing a thrombosis. You can use bare metal stents or covered stents, which have a fabric lining.
Is one better than the other?
Covered stents might last longer for chronic disease, but there's that infection risk again if there's dead bowel nearby. Angioplasty without a stent is generally not advised acutely. The artery often just narrows down again. Stenting provides scaffolding.
Are there other ways to get clots out endovascularly besides drugs?
Yes, mechanical ways. Percutaneous embolectomy uses little baskets or snares on catheters to grab the clot. Pharmacomechanical thrombectomy combines a small dose of clot buster delivered right at the clot with suction or mechanical disruption to remove it.
Faster than drugs alone, I guess.
Generally, yeah. Less systemic drug exposure. But there's always a risk with mechanical methods that bits of clot break off and travel further downstream, which can be hard to deal with. And, crucially, even after successful endo treatment, you still need to check the bowel, usually with laparoscopy or open surgery.
Right, fixing the pipe doesn't guarantee the garden is okay.
Exactly.
Then there was this hybrid procedure mentioned, retrograde open mesenteric stenting, or ROMS, combining open and endo.
Yeah, it's a neat technique. The surgeon makes a small incision to get direct access to the mesenteric artery, then uses wires and catheters, just like an endo procedure, to place a stent across the blockage, but approaches it backwards, retrograde.
Why do that? What's the advantage?
A study showed it works well and is safe. especially for blockages right at the origin of the artery. It can be good when the anatomy makes a standard endo approach tricky, maybe due to vessel twists or calcium, and maybe less infection risk than a full open bypass if there's dead bowel because the surgical exposure is smaller.
But still needs follow-up, like other stents.
Oh yeah, stents can still narrow down over time, so surveillance is key.
Which brings us to assessing the bowel itself. How do they decide what needs to come out?
The general rule is restore blood flow first if possible. Give the bowel a chance to recover. The exception is obvious perforation, a hole that needs immediate surgery. But otherwise, revascularize, then assess.
Because operating when there's no blood flow is pointless if it's already dead.
Right. And you don't want to take out bowel that might recover. During surgery, either open or maybe laparoscopy after an endo procedure, they look at the bowel's color. Does it contract peristalsis? Does it bleed when cut? They might use a Doppler probe to listen for blood flow.
And they try to be conservative.
Very. The mantra is, when in doubt, leave it in, because the consequences of taking too much bowel are devastating short gut syndrome. That's why the second look operation is so important.
Explain that.
You do the initial revascularization and maybe remove only the obviously dead bowel. Then you plan to go back to the OR 24-36 hours later, maybe sooner, if the patient worsens. Often use a temporary closure device on the abdomen to make re-entry easier. This gives time to see what recovers and what definitively needs to go. It's a crucial step to save as much bowel as possible.
Makes sense. What are those other considerations? Intraoperative vasodilators.
Yeah, even after you fix the main blockage, there can still be spasm in the smaller vessels. So during surgery, they might infuse a drug like papaverine directly into the SMA to help relax those vessels and improve microcirculation.
Does it work?
It can help. Glucagon has also been looked at, but isn't standard. You have to be careful, though, because vasodilators can drop the patient's overall blood pressure, so you need good fluid resuscitation alongside it.
And the last point was long-term surveillance. Why is that so vital?
Because bypass grafts can fail, stents can narrow down again, restenosis. You can't just rely on the patient feeling okay.
So regular checkups aren't enough.
Not enough. You need imaging. The Society for Vascular Surgery recommends it. Duplex ultrasound is usually the first choice, non-invasive, uses sound waves to check flow.
Is it easy to interpret after surgery or stenting?
It can be tricky, actually.
Yeah.
There aren't perfect universal standards for what ultrasound velocities mean restenosis after these procedures. But the general guideline is get a baseline scan soon after treatment, then repeat it 6 months, 12 months, and yearly.
And if the ultrasound looks suspicious or symptoms come back?
Then you move to CTA or MRA for a more detailed look. Proactive surveillance is key to catching problems early.
Finally, that algorithm in the chapter seemed to tie it all together.
Yeah, it's a good visual summary. Starts with suspicion, the severe pain, nausea, etc. Then immediate steps. Assess stability, physical exam, get that stat CTA, run labs.
Then it branches.
Right. Based on whether there are signs of peritonitis or definite bowel necrosis already. If yes, it usually points towards surgery first, maybe palliative care if it's hopeless, or revascularization plus resection if viable bowel is found.
And if no immediate peritonitis?
Then prompt revascularization endo or open, followed by surgical exploration to assess the bowel, remove dead segments, and strongly consider that planned second look, especially if viability is uncertain or the patient is unstable. It guides you through the critical decisions.
Okay, so wrapping this up. AMI, serious, life-threatening, multiple causes, tricky diagnosis, where imaging like CTA is crucial. Treatment is all about restoring blood flow, fast surgery, endovascular, or hybrid, and then managing the bowel damage, often with that second look surgery.
That sums it up well. Huge progress has been made, but it's still a massive challenge requiring quick thinking, accurate diagnosis, and skilled intervention.
Absolutely. This dive really underscores how vital our vascular system is. And thinking about things like AFib becoming more common or population aging, it makes you wonder, right? How will our approach to AMI keep evolving? Are there new diagnostic tools or treatments on the horizon that could push those survival rates even higher?
Those are exactly the questions driving research. Better imaging, less invasive therapies, maybe even ways to protect the bowel during ischemia or target NOI specifically. There's definitely potential for further improvement as we learn more.
Fascinating stuff. If you, listening, found this deep dive intriguing, definitely check out the source chapter or related research. There's always more to learn about critical conditions like acute mesenteric ischemia,